in our theme of neurotology across the lifespan. We'll start with pediatric neurotology, and no person better than Rob O'Reilly to moderate a panel on pediatric neurotology. Rob, thanks so much for moderating, and enjoy the panel.
Thanks so much, Brad. It's really an honor and a privilege to be here presenting this. I want to thank the whole ANS scientific committee for putting this together, and I really want to thank you, Brad. Brad's always had an eye to kind of looking at across the lifespan, and I've known him for a long time, and it's been a pleasure to kind of see that grow. So I think we have an exciting panel. It's about an hour. For the viewing audience, I'd ask you to send in your questions or comments. We'll try and select a few as we work through each case. I'd rather do it that way than at the end if possible, because we might forget the cases. Now, we put way too many cases on here, so we'll see how many we get through. We just wanted to give a flavor for different things that we see in this age group. And I think you'll find that there's no right answer for this. So it's really nice to pick everybody's brains here. So here's our star-studded panel. We have Sharon Cushing, who joins us from the University of Toronto. John Dornhoffer, he doesn't need any introduction. He's in Arkansas, as everybody knows. And he's really the old brains on our team here. Tina Huang is joining us from the University of Minnesota, and Stephanie Moody Antonio from Eastern Virginia Medical School will be here as well. So here's the disclosures, just a disclosure side for the audience. And let's launch into the first case. So I'm going to be introducing some of the cases in terms of the history, and then I'm going to ask the person who's kind of the primary on the case to give us some analysis, and then we'll have a discussion. So this is a 2-year-old boy with bilateral profound sensory hearing loss and developmental delays. And of course, in part of the standard workup, we got some imaging on this patient. So Steph, maybe you can tell us kind of what your impressions were when you first looked at this CT scan.
Sure. So this little boy had some additional developmental delay and things of that nature. So he's always a little bit hard to test with respect to his hearing, but he also has a mild abnormality of the pinna. So it wasn't unexpected to find some abnormalities of the inner ear. But you can see on the scan, on a CT scan here, the pretty severe abnormality of the cochlea. The horizontal canals looked pretty good, maybe a little bit of dilation of the vestibule, but the internal auditory canal is sort of bulbous, and there's a really very little separation between the cochlea and the IAC. And then you can see the malformation of the cochlea, kind of this globular thing that sort of still has the shape of the cochlea. So this was your classic IP3 malformation. And then we did the MRI scan to kind of get a closer look at the nerve. And it did look like he had a pretty healthy auditory nerve going into the ear. And you can also see on this scan that this was a bilateral malformation. So it was pretty consistent with the PO3F4 mutation or X-linked deafness. He did have abnormality of the stapes as well. And I think this picture shows a little bit how you can see the facial nerve sort of coming across the front of the cochlea. And on the previous scans, you could see that the facial nerve looked like it kind of crossed over where the oval window should be. On this side, the round window looked, it was at least somewhat evident. And the other side was a fairly similar findings. So then the question was, here's a child with profound deafness and this malformation. And we started thinking about cochlear implantation. There's a few case reports out in the literature. This was the first time I had seen a case like this. So I learned a lot about it in the process, but some of the things that we were kind of thinking about is the lack of a bony partition there between the basal turn of the cochlea and the IAC. So number one, a risk of inserting the electrode into the IAC, and number two, that we could expect a CSF gusher, and then how to sort of deal with that. But the other thing I thought, really about electrode choice initially, I think my biggest concern was I didn't want to misplace the electrode into the IAC. I just didn't want to be that person, I guess. So I thought, well, maybe I'll try a pre-curved electrode that will just kind of follow the basilar turn and kind of sneak into the cochlea and avoid going into the IAC. But I'm definitely curious about what other people would do in that case. I ended up doing the curved electrode on the first side, and then sort of retrospectively thinking, well, if he doesn't have a medialis, where are the neural elements? And I really, haven't been able to figure that out yet. I know that with common cavity malformation, the neural elements can be on the outside wall of the cochlea, but this is a little bit of a different malformation, and I don't think it's clear. I haven't found anything out there in the literature to suggest, so I'd definitely be open if somebody does know the answer to that question. But I decided, because he wasn't doing very well on that first side, to do a straight electrode with a full banded design on the second side. So you can kind of see the difference on that postoperative plain film, what the right side looks like compared to the left side. So
did you use any imaging modalities when you were doing the insertion? How did you tackle that?
Yeah, I know some people have access to intraoperative CT scan. I don't. I have fluoroscopy, so I did sort of set him up so that we could kind of do fluoro intermittently as I was inserting. So I'd insert it a little bit, take a picture, insert it a little bit, take a picture. That's how I did it.
Okay. Any of the other panelists, how would you approach the insertion on this type of a malformation?
I can speak to the fact we've had about 5 of these kids, many of whom have gone on to bilateral. And I am that person that did put the electrode in the IAC, so I can tell you what not to do. And the problem there was related to, we used a pre-curved electrode and we didn't advance it off stylet. And so that allowed us to insert it straight into the IAC. And so we did take that kid back because he left the OR actually with the electrode in his IAC. And we now always use fluoro. In terms of the electrode selection, I honestly don't know that it matters, because I just think about electricity and I think about the fact that this is a fluid filled cavity. And so I think if you get electricity in there, we're not watering this little flower with a beautiful dainty watering can. Like, this is a fire hose. And so I think that while we like to talk about the idea of what kind of electrode, I'm not sure that it matters. Electricity and water, it's going to get there regardless, I think, of what you use.
Yeah, so that,
any thoughts on the electrode?
Yeah, I've only done a handful of these cases, and I think Steph brought up some really interesting points about where the neural elements are. And I think the fully banded electrode's a cool idea. I think even though they don't have habenula perforata, I think the nerves are probably similar, because before these boys lose their hearing, they oftentimes have audable and tonotopic represented ears. I have 2 issues with this. One is that this is a CSF leak. This isn't the little pulsation of an EVA. You open the cochlea and the ear fills full of CSF. So that's one thing. What are we going to do to stop it? Second thing is, how are we going to keep it to go into the IEC? I've heard from some friends that when you do the neurotelemetry, that if it's in the canal, oftentimes will stimulate the facial. So even without radiology, you'll get the facial nerve monitor go off. But what I do, this is the one time I picked the electrode, and I like the cochlear 612. The reason I like that is because I can leave the stylet on, and I put it in a little. I always do a cochleostomy for sure, because going in through the round window or an extended round window, I have to figure out how I'm going to stop the CSF. And I like about the 612 is that it has those 3 little rings on it. And if you do a 1 millimeter cochleostomy, the ring will pop through, and oftentimes without any tissue, the CSF leak stops. And also, I'll put the electrode in, so instead of following the medialis like normal, I'll actually have the tip pointing forward, push it with the stylet on until I hit the lateral wall, the first spin, then rotate it 180 degrees, push it a little bit more, and then advance off stylet. And I've had pretty good success using that, and the CSF leak stops pretty well.
Very cool. Steph, did you get a leak on this one?
Yeah, he leaked. But I think, I was prepared for it. So we just kind of waited for the pressure to slow down a little bit and then inserted the electrode and a little bit of muscle and then some fibrin glue. And it wasn't too bad in that case. I think John brings up a couple of good points. The other device that's out there is the Medell device with the little pledget at the end, and that may be very helpful in case of a CSF leak. I think the other, not to belabor the issue, but the other thing that I wasn't sure, my audiologist and I are still kind of trying to figure out, I did not get full insertion of either electrode. He's actually doing better with the left ear than he is with the right ear. And on that right side, where these
CSF leak stops.
on that right side where the device is kind of curled tightly, I wondered if maybe those top 6 electrodes are just kind of conflicting with each other. So we kind of discussed turning off those to see if that made any difference.
Yeah.
With the CSF leak in these ones, we like to, one of the things we found really handy is to actually have 2 sections on the setup, and the assistant brings one section in from above, and then you don't have to wait for it to slow down. And so that's been really helpful with these because they are rubber boot needed CSF leaks.
That's a great point. Great point. Well, that's a challenging case for sure. I think we all get a little bit uptight when we approach these, but it sounds like you had a really good outcome there. So let's move on to another case. So this is a 14-year-old patient with Down syndrome, has had multiple sets of tubes, which is pretty typical in this population. Does well while the tubes are in. At age 10, the right tube extruded, leaving a subtotal perf, incus necrosis with a moderate mix loss. He was repaired with an incus interposition and underlay with temporalis at an outside hospital. This is John's case. Current audiogram showed a mixed loss, 40 dB at 500, 20 at 2000, and 4000. And this is a view of the right eardrum, which is kind of the classic saran wrap eardrum, I would call it. And you can see the promontory there through the center and what's left of the ossicles and the incus interposition on that upper left side. So this was the situation that he was faced with, atelectatic TM, T-tube in place with some atrophy. The Valsalva sign was negative. There was no sinus disease. Had a TNA, wouldn't use nasal steroids, which is pretty typical at this age, or otovent, and had this retraction pocket, which was shallow but was collecting debris, had to be cleaned periodically, but with difficulty because of the, some of these patients, they don't tolerate that very well. And the CT scan showed a sclerotic mastoid, but no obvious cholesteatoma. So before you tell us what you would do with this case, Tina, maybe you can take a step. How would you handle these Downs kids that they're fine with tubes, they spit them out very quickly, and then they end up with this tympanic membrane that's lost all of its elasticity?
Yeah, so when I looked at that picture the first time, I mean, for sure, I went, oh boy. It does make a difference that he's 14. I find that the less time somebody has had to have a really fully atelectatic TM, the slightly better it might come off of the middle ear mucosa and off of the ossicles. So on a kid, I might actually try to pull that TM up and put a whole lot of cartilage down, take out the old prosthesis, probably take the malleus out as well, just give him a type 3 tympanoplasty, and then put a tube in, either through the cartilage itself. That hasn't always worked great for me. A lot of times they just plug up. But the other thing I might think about is, so for an adult, I've tried this before. It hasn't really always gone well. I've left a lot of bits of skin behind, which I wasn't super excited about. But to actually just leave the TM completely down, give them a wall down, basically, and not touch the middle ear space at all, and just line the mastoid cavity so that he's got a cavity to clean and everything's exteriorized.
Yeah. When you do the cartilage, do you take one large piece? Do you palisade it? Kind of what's your go-to?
So if I'm going to take the malleus out, then I'll try and take really one large piece that encompasses the entire TM. In that case, then I do have to put a tube through the cartilage.
Gotcha. Yeah. Steph, how would you tackle this?
But I would have some of the similar kind of thoughts. One thing that I was wondering too is if this person had any effusion or if it's just a retracted atrophic drum. So is there ongoing eustachian tube dysfunction, or is this just a result of prior? I mean, probably it sounds like it's ongoing eustachian tube dysfunction, and then, you know, is there any way we can deal with that? You know, eustachian tube dilation has been used in more settings than maybe traditional. I don't know that it's been used yet. Maybe Dr. Poe's out there can comment whether it's been used for Down syndrome patients. And I know that there's some experience in developing with respect to dilation in children, but that might be one thing at least to have a passing thought about. The other thing I might wonder, and I think people can debate whether doing a mastoidectomy in this case would be helpful, whether that would help aerate the middle ear or not. I had the same worry about the manubrium because the manubrium is so medialized that trying to fit a cartilage graft under the manubrium can be pretty difficult. And then finally, I wondered, well, you know, cleaning the ear every 3 to 4 months is not optimal, but if this is a stable perforation versus a progressive perforation, if it's stable, you know, maybe the person, I doubt it, but maybe the person would tolerate wearing a hearing aid and then avoid having surgery at all.
Yeah. Sharon, what do you think?
We love hearing aids in these kids. And so, Stephanie, I'm glad that you mentioned that last option, especially if he's, you know, he was compliant enough to get that beautiful picture. So I imagine he's probably compliant enough to let you clean out the ear. So, you know, put a hearing aid on, get him hearing well, you know, and then you have a bit of the luxury of time. You got a beautiful result in this situation, but with these kids, we tend to get the hearing good and then decide what to do from the ear, from a surgical perspective.
Mm-hmm. Yeah. What about, before we go to John's solution, which is quite elegant, what about protocols for ear surgery in Down's patients and their atlantoaxial joint issues? What do you guys do? Do you order those films yourself? Do you refer them to orthopedics? Yeah, because my understanding is the rotation of the neck is worse than the extension.
So this is Tina. So for me, I typically do not get an x-ray. We just make sure that when we are in the OR that they're not extended and unfortunately not very rotated, which doesn't make for the best ergonomics when you're operating. But, you know, as we all know, with our large obese patients with the non-mobile necks, it can be done. Yeah. Not the funnest thing ever, but doable.
Yeah. Excellent. Just wanted to mention one comment about our last case. Dennis Post said, in difficult cases, agree with full banded straight electrode. There have been anecdotal reports of pre-carved electrodes passing into the IAC and becoming entangled with the facial nerve, making removal difficult. So that's a real, very interesting technical point. So let's, John, why don't you carry the water on this one and tell us what you did?
Well, I kind of put this group, this isn't a special case. This is what I call, you know, the Belushi 4. This is how I deal with kids with Down syndrome, Turner syndrome, cleft lip and palate, Crouzons. These are what I call pervasive eustachian tube dysfunction cases that I don't think are going to get better with age or any sinonasal disease. And what goes through my head with this case, one, a lot of these kids with Down syndrome develop sensorineural hearing loss later and do require, you know, they already have some impairment of their hearing. They're notoriously difficult to put hearing aids on because their canals are so small. I used Bajas on them and reported my experience with Down syndrome. We had 24% had to go back to the operating room at least once for complications. So you're really kind of stuck with these cases. So my thought process is that He needs ventilation, but you're in the damned if you do, damned if you don't. You have a big perforation, you need ventilation, but the size of the perforation is causing hearing loss. So the best of both worlds is to close the disease, in this case, atelectatic ear, try to get as much hearing as we can, but create something that's a fairly permanent ventilation solution. So that was going through my head. So I really don't like Baja in this group so much because of the complication rate, and hearing aids are difficult. So the technique I usually use on the Downs kids is what I'm going to show you in the next slide. So basically, this is a cartilage perichondrium island flap. The case had an incus interposition, which was removed. In the atelectatic ear, it's a typical situation. You can put a tube in these atelectatic ears and it's going to stay 3 months. So that's really not an option, is to try to tube this ear again. So this is a perichondrium cartilage island flap harvested from the tragal. And even though I took the malleus because the skin was medial to it, I still remove a little bit of a slit in the middle so that I can place the anterior island, pack it firmly against the anterior annulus, pick up the posterior island, and use a PORP that uses the posterior edge of the anterior island as a neomalleus, which gives you a consistent length of 2 millimeters for a PORP and 4.5 for a TORP. Then I use a 5 suction to make a little cookie bite, and I put a T-tube through it and insert the whole graft. And I've been using this in Downs kids since the 90s. And the tube, sometimes if they're able to Valsalva and blow air out of it, like in the cleft lip and palate kids, then you can remove the tube in clinic and it heals up nicely. If not, I've had some of these that have stayed 20 years. So the next picture kind of shows, this isn't this particular case, but this kind of shows the postoperative appearance. Oftentimes you'll get some cerumen around the edge of the tube, but usually the tube can't extrude because it's within the cartilage. So this is a typical postoperative appearance.
Oh, that's fantastic. So a couple comments and questions. First, Peter Weisskopf, anyone consider a lateral graft, perhaps even stage with reconstruction and tube if needed, question mark. Opens canal and completely resets TM position. So what do you think about the lateral graft in somebody like this?
I personally am not a big fan of lateral grafting because you can, but I worry about blunting. I worry about lateralization. And with cartilage, you don't have to worry about either one of those because you put the cartilage island under the anterior annulus and you pack it, so lateralization and blunting is pretty rare. Now, that's just because I wasn't trained in lateral graft techniques. So I'm not critical of that anyway, but in my own hands, I'm not fond of it.
Yeah, I agree. I found that you really have to put a nice rosebud pack in there and take it out. And then you got granulation tissue in the canal, and you got to debride that. And some of these kids, as you know, and you mentioned in this history, or just won't tolerate it in the clinic, or it's extremely difficult. So yeah, I typically do the cartilage like you do. Anybody else? Anybody do a lateral graft on this?
I can stick up for the lateral graft people. I mean, I don't know about this case in particular, but I think that the lateral graft technique can be very, very useful. And sometimes the eardrum ends up looking like nothing ever happened to it, like a beautiful brand new eardrum. So it's a very nice technique, a very reliable and flexible technique. In a case where you have retraction, with the lateral graft, you may still end up getting retraction, but especially if there is, a reason to maybe stage it, like you were concerned about the skin that was stuck on the stapes or something of that nature, then when you put the silastic in and you put the lateral graft in, it heals. Silastic keeps it from retracting and kind of makes it a little bit denser too. And so sometimes that's pretty effective. So, I think it's a good technique, and I find it useful in kids. I definitely do, since I do a lot more peds. I do a lot more medial grafts, but I may end up being about 50-50. So.
Right. So here's the post-op follow-up, and you can see really an excellent result and very stable. So.
Yeah, nice.
It's a great pearl. So this is Tina's case. Tina gave us some very tough cases. There must be some very complex kids in Minnesota because these are not fun. So,
well, I picked out the hardest ones that I could think of. And one of them was just a girl that just keeps on giving, unfortunately.
Yeah.
So this is when I met him the first time, he was only 13 months old, and he came in with a right hearing loss and an abnormal ear exam. He was sent by an outside ENT because of noted hearing loss, although he actually did supposedly pass his newborn hearing screening. I'm not sure how that was actually possible. And the pediatrician had said that there were effusions in both ears, and that mom had been told every single time she brought him in that there was always fluid in the right ear. And so the outside ENT had tried to put in tubes in, and on the left side went in easy. And yes, there was an effusion, but on the right side, when she went in, she couldn't get anything in because she got through the skin and then just hit a wall of bone. At the same time, she did take off 2 little skin tags on the right side as well. Next slide, please. And so this is after the left ear tube. So obviously sound field is just giving you what the left ear is hearing. And he's got a nice high volume flat timp on the left and the low volume timp on the right. Next, please. So when I saw him, the auricle itself looked pretty normal. He did have 1 little skin tag right in the preauricular area that had been removed, and 1 on the right cheek. The ear canal was really quite narrow, difficult to see the TM, and it was red. You really couldn't see through it at all. And the left ear itself actually was completely normal. So we went ahead and got a CT scan. And I'm sorry, it's difficult to see on these scans, but where the TM should be, he clearly has an effusion. You can see a thin white line where the TM is essentially fully ossified. So I went ahead and took him to the operating room, and using a laser, got a T-tube in. And I had to actually use one of those little tiny infant speculums because his ear canal was so small. So lasering it was fine, but getting the tube in was a little bit tricky. And he had a really thick TM, and underneath, yes, a completely fully ossified medial layer, I suppose. And there was a thick mucoid effusion in the ear. And so after we sucked it out as well as we could and put the tube in, I just had a really low frequency conductive loss on the right. So he's been doing well for a while until just recently. Last year, so in 2019, he came in with an audiogram, and that was very similar to what we had on the ABR, just a mild conductive loss. But then last year, after he had a URI and some right otorrhea, his conductive loss dropped quite a bit. And we just sort of chalked that up to the fact that he just recently had otorrhea. It was still infected, it was still inflamed. And so, we're like, hey, we'll just watch that for now. But his follow-up audiogram, next slide, please, which was just a couple of months ago, showed that his low frequency conductive loss has worsened quite a bit. Although his high frequency loss is sort of back into that mild range. So maybe just a little worse than where he was right after he had his tube placed. Now, mom did say that he had a little bit of a cold symptom, just a little bit of a runny nose and a slight cough, but nothing terrible, and certainly no otorrhea. So when I saw him in clinic, again, he has this still very tiny ear canal, and all I can see when I look in the ear canal is basically the T-tube. I can't see around it at all. I can't see through the tube. So my question to the panel and anybody else is, what do we do now about this kid?
John, you can solve this. Any thoughts?
Yeah, this is an interesting one because, you can get the eardrum turned into bone through an acquired situation, but this occurred at 1 month or at 10, 12 months of age. So I'm assuming this has to be a type of partial atresia. And the audiogram's consistent with that. Usually when I've seen these, there's some eardrum in back, but then the malleus is fused to the anterior, the anterior canal wall, what should have been the drum. And that does give a conductive loss that's in the low tones and then closes up at 2K and 4K. So that's consistent. The problem is eventually this kid's going to need a canaloplasty and a kind of an atresioplasty, but you're probably going to have to take the skin out and graft it somehow. So if you have that situation with chronic otitis media, it's bad because you can't put a rosebud in, you can't put a tube at the same time like I just showed you with the last case. So what I'm going to do with this kid is I'm going to kick the can down the road, maybe do a TNA, maybe try to clean up the eustachian tube dysfunction and treat it just like tube otorrhea till he gets to about at least 4 years of age. And I'm probably going to do a post-auricular approach canaloplasty, drill that bone away carefully, not to open it up, disarticulate the chain right away so you don't cause a sensorineural hearing loss by drilling on the malleus, and then take the chain out, reconstruct with a canaloplasty and total cartilage graft. But I wouldn't do it yet if he still has eustachian tube dysfunction. I'd kick the can down the road.
Yeah, that's smart. Steph or Sharon?
Well, I agree with everything John said, but the caveat to that is right now we don't know whether that tube is maybe plugged. Maybe he's just developed an effusion again. So see if you can tip that tube back, or, if not, I don't know if you want to go to the OR to do that, or if you want to get another CT scan, but I would first make sure, especially since it looks like the hearing loss recurred, that tube is patent and that middle ear effusion is not an issue. And then if that's the case, then yeah, as John said, I would proceed in that direction.
Tina, what kind of tube did you use on this kid?
So I put a T tube. I cut it down. So I sort of treated it as if I was putting it through cartilage, essentially. So I was just putting it through bone. So I cut the legs down so it would fit because he has a pretty small middle ear space. And I cut the shaft down too because he's got such a stenotic ear canal. So my concern is that, yes, as Stephanie said, there's something going on with the tube. Even though he has what looks like a higher volume tympanogram, again, I'm pretty sure that when I looked in his ear the first time after surgery, it wasn't that all I could see was the tube. So my guess is it's moved, shifted, maybe partially extruded. So I am going to take him to the operating room, take a look at the tube, take a look at the eardrum. If it's closed or plugged or something, we'll reopen it, suck out whatever's in there, and hopefully put a new tube in, and that'll help. But yes, my concern is, as John said, that there's some progression of the ossification, and that at some point we're going to have to do something a little more than just tubes for this kid, but not maybe right away.
And while you're there, you can also palpate the eardrum and the malleus a little bit to see whether the malleus is fixed.
Yeah, his eardrum the whole thing is actually fully ossified. There's just nothing there. Really odd. But I'm sure he does have an atresia, a partial atresia, because again, his ear canal is teeny tiny.
Yeah.
I think, for us, we'd probably take a step back. I admire the efforts that you went through to put the tube in, Tina. But I think, this is a young child who needs access to sound. And so, how else can we potentially achieve that? His canal might be too small for a conventional aid, but, we work with some pretty amazing hearing aid specialists that can mold, quite a few canals. Otherwise, I get a bone conduction aid on and get rid of the tubes, in all honesty, and sort of back away from the surgical perspective in order to try and get this child consistent access to sound. Parents don't always love that option. They prefer let's put a tube in and get the hearing normal without having to put a hearing aid on. But I would treat this kid like we would either our kids with Downs whose canals are too small to access their OME, or our atresia kids. I typically, like the panelists have said, waiting and thinking about surgical canaloplasty at 5 or older if the family wants, or a surgical bone conduction aid is also a great way to get good hearing in these kids, which I think developmentally is what they need.
Yeah, so he actually is being fitted for a hearing aid.
Yeah, that's great.
I think, Rob, this brings up a kind of an interesting side conversation. I totally agree with you, Sharon, but I don't know. I think I also find a lot of resistance to kids wearing a hearing aid. This child was, how old is this child? I forget.
He's now about 3.
So 3, you can make it happen. 3, 4, 5, 6, 7, you can get the kids to wear hearing aids. And we have a couple of cases coming up where the kids are a little bit older or with a unilateral hearing loss, or I just have had much less success with kids, even though I might recommend it because that's my job. But if they're doing well in school and they're really not showing any deficit from the hearing loss, getting parents to agree or an older child to wear a hearing aid can be definitely a challenge.
Yeah.
Especially your ball. We can talk about that more. There's a few cases to kind of illustrate that issue too.
Yeah. Let's pop into the next one. So this is more of we thought an important topic than a case. So it centers around, obviously, 6 months old, failed newborn hearing screening with obvious hearing loss, temporal bone IC imaging normal, genetics came up negative, no family history, and no trauma history. And so we wanted to talk about CMV and the protean manifestations of CMV and damaging the inner ear, both the cochlear and the vestibular part. So Sharon, why don't you give us a little tutorial on this?
Sure. So, congenital CMV, I was trying to think of, what's a demonstrative case? And the truth is that there isn't a single demonstrative case for congenital CMV because they're everywhere. And they're in our practices, whether or not we recognize it. So I just put up some scenarios here of different cases that we've managed, all of whom have had congenital CMV as their etiology. So passed a newborn hearing screen, presents with a sudden loss at 5 years of age, either unilaterally or bilaterally, failed the newborn screen and presents as a congenital bilateral profound implant candidate right from the get-go. The kids who fail their screen and present with a congenital unilateral profound hearing loss, those who present with progressive asymmetric losses, these kids are in our databases, with their etiologies labeled unknown, but underlying it all, they have congenital CMV. The final one I'll put in there is that they, pass their newborn hearing screen and presents, with episodic vertigo and sudden sensory neural hearing loss. Again, that's a big red flag for, does this child have CMV? And, because these kids, not only do they get cochlear loss, but they also get vestibular loss. And Rob, I don't know if you want to speak to your experience with these kids from a vestibular function perspective.
Yeah, I think there's some of the worst hypofunction cases that I've ever seen. The rate of areflexia in the CMV kids can't be underestimated. And of course, that can be an issue. When you do the CI and then repetitive trauma, as some of your data out of Toronto has shown. So I think it's important to have that kind of in the forefront of your thinking as a child gets older. 2, 3 years of age, you can get some information. By age 5, you can get, the full enchilada of vestibular testing. So I think that's an important consideration for sure.
You go to the next slide, Rob. I essentially wanted to, try and make a synopsis of why I think CMV is so important. And, the first thing is that it's common. And so it's it's even more common than sensory neural hearing loss from a congenital perspective. And if you advance, Rob, I've put up the US prevalence essentially translates into 20,000 cases a day, about 5% of which will likely be CI candidates. And this is an underestimate in the sense that a lot of these cases aren't recognized. And so we can do retrospective diagnosis. And so if you advance, Rob, one of the best ways one of the most effective ways we can do that is by seeing these kinds of changes on our imaging scan. So we not only do IAC imaging with MR, but we do brain to look for these non-specific white matter changes in temporal lobe cysts, which are pathognomonic. And your radiologist, depending on their familiarity with it, may just read it out as non-specific white matter changes. But in otherwise vaccinated countries, this is CMV till proven otherwise. And I've got a bit of a fun image if you advance it to the next one, in that in Canada, sometimes we even are able to pick it up. This is a fetal MRI. And so this baby was found to have CMV on fetal MR. Again, you can see the temporal lobe cysts. The other thing is dry blood spot testing retrospectively, which is not perfect. It's got a high false negative rate, but many states keep blood spots for a long period of time. So accessing those can be helpful in terms of making a retrospective diagnosis for the families. And then just the final point, if you advance the slide, Rob, is just the importance in the setting of our kids with single-sided deafness, either congenital or progressive or sudden in onset. And by far and away, this is the biggest group of kids with SSD that we implant. 40 to 50% of the kids that we have implanted congenitally for single-sided deafness have CMV. And the reason that's so high is that, first of all, other than cochlear nerve aplasia, it's the single most common cause of implantable SSD, because we wouldn't implant the no nerve kids. And this data speaks to the family in the sense that these kids, if they start off with a congenital loss, the probability of developing bilateral hearing loss by the time they're 18 is 75%. And so that speaks to them with respect to wanting a single-sided implant. So those were my 3 reasons why CMV is important and why we should look for it.
Right. So among the group, what is the status in your states in terms of CMV screening? In Pennsylvania, they're trying to introduce some legislation to make it part of the newborn hearing screening with the blood spot. But can you give us news locally?
I can tell you about Virginia. We passed, Dr. Barry Strazink and I work with our legislative branch, and we passed a law 2020, and it just, 2019, and it just went into place just this past September. So since September 1, all the babies that failed their newborn hearing screen are being screened with a swab test. The swab test, it was really a game changer because before that you had to get urine and the baby's getting ready to go home and mom wants to leave and you got to get urine from the baby and put a bag on the baby. And it's just a big giant hassle. It's a hassle in the pediatrician's office, so they didn't want to do it. And it was definitely going to be a hassle in our office, so we didn't want to do it. But when the saliva swab came out, it's a PCR test, it became very convenient. So we started doing it in our office just as part of our newborn hearing screening protocol. And then we started having some of our birth hospitals have been doing it. And then finally, that's how they're doing it through the newborn hearing screening program in our state. So that's been definitely a game changer. And I would just kind of reiterate that this is a very important thing, and it may represent the diagnosis in 1 out of every 5 children we see with hearing loss. So, we never really looked for it before because what are we going to do about it? But now, maybe there is some opportunity for treatment with valganciclovir if we see the babies soon enough. The clinical trials are ongoing. Dr. Park has a big clinical trial through NIH that is still looking for patients. And, so if we see that the valganciclovir actually changes the course of hearing loss, that's a huge game changer for these children. So if we can stabilize or we can reverse the progressive hearing loss and prevent some of these children from having to go on to cochlear implants, that's just huge. I'd say another point about the dried blood spot, it's definitely not as sensitive. In Virginia, they save our dried blood spot specimens for only 6 months. So when you get the child who's a year old, you're like, I can't even make that diagnosis, even though I think that might be it, unless of course they have something in their brain. So if you do have the opportunity to see these kids during the newborn hearing screening process, and you can do the swab technically within 21 days, maybe you can push it to 30 days. It's very easy to do. So think about it. But I think this whole CMV idea is such a game changer in pediatric hearing loss that we just didn't have at our disposal before. And now we're able to make that diagnosis in children before we just would have to shrug our shoulders and say, I don't know what caused your hearing loss. It also helps us identify those kids, even if their hearing might be normal, but we know they had congenital CMV, or maybe it's mild, or maybe it's unilateral. We know that we have to keep a closer eye on those kids because their hearing loss is, more likely than not to progress over time.
We had a good question. I've had several CMV patients lately. How hard does the panel work up other congenital causes in the setting of known CMV? And I think that's very timely. I think Richard Smith's group just came out with a paper recently showing that significant number of kids with known CMV also had a genetic loss. So just a quick straw poll, who gets imaging or other workup on kids that you know have CMV? Tina?
Yeah, I still would. In Minnesota, we do not have CMV as part of our torch testing. And so there's definitely been a push over the last probably 3 years to try and get it into the newborn hearing screening panel. Our blood spots luckily are kept for years. And so just recently, actually in the last 6 months, we had a child who was 5 diagnosed with congenital CMV because we were able to get that blood spot. And again, that was due to progressive loss on his only hearing ear. And then another child who was even a little bit older who was diagnosed with congenital CMV. But yeah, I do routinely get imaging depending on the age of the child. I would start with a CT because often you don't have to sedate them, but I know MRI is obviously a much more useful tool for CMV.
Right. Let's move on to the next. I just had one comment I didn't get to. It was interesting. Craig Buckman said about your case, Tina. Bony plates under the tympanic membrane can occur congenitally in Fanconi's anemia. So that's an interesting point there. So let's move on to the next. So this is a Steph case. This is a CI patient with charge, 12-month-old. Maybe Steph, you walk through the case. I think you're muted there.
Unmute. So this is a 12-month-old with bilateral profound congenital progressive hearing loss. He had all the features of charge syndrome. Generally healthy other than that, little bit of facial paralysis, or I should say complete facial paralysis on the right side, bilateral mild, microtia worse on the right than the left. And he did have some recurring otitis media. You can go to the next slide. So this was a representative CT and both sides were fairly similar. So he has sort of this cochlear hypoplasia. He has a residual vestibule, but the semicircular canals are all missing. The ossicles are malformed and fused. And then you can see on the bottom left image that the facial nerve kind of crosses right over the oval window, and there's no stapes. But then importantly, so thinking about cochlear implantation, you can see a little bit of a residual round window area. It looks like it's closed over though. So I knew it'd be a little bit hard to identify. And then his mastoid was the problem. He just had really no aeration of his mastoid. He has some epitympanum, but no real mastoid, no facial recess to account for. I showed a picture of the MRI scan there too. He does have a cochlear nerve. It's probably a little bit hypoplastic. Yeah. So just kind of a close-up of those two critical things. There's the facial nerve on the right side picture and the picture of the round window on the left side picture. So then the question was, well, how am I going to get a cochlear implant in there? And I ended up doing both sides. So the first side was a little bit more trial and error. The second side, I knew exactly what I was going to do, so it went a little bit easier. I had similar questions about which electrode to use on this case and ended up trying to use the contour device on the right side, which retrospectively was difficult. So you can go to the next slide and I'll show you the approach that I decided on. So on the far left, this was basically a suprameatal approach. So that's the epitympanum. The tegmen is very low. You can see the ear canal, soft tissue kind of pulled anteriorly. And you can see I scooped out a place to help there's no air cells there, but I wanted some place to kind of coil my excess electrode. And then you can see the little channel that I drew. But now obviously I can't have access to the round window through this approach. I could see the Malleus incus blob. But what I ended up doing was using an endoscope transcanal, so that's the second picture here, to help identify the cochleostomy, make the cochleostomy. Initially, you can kind of see, here's the incus, the stapes is missing. That's the facial nerve coming right across where normally you would see the oval window. And then you can see the promontory. Now, my next tour was to find the cochleostomy, or I couldn't find a round window. On the right sided picture, you could see I kind of drilled out the area and started drilling a little bit kind of maybe posterior to where the incus was. And I started getting some blue lining, but I didn't feel like that was the cochlea. I thought maybe I was getting into the vestibule. So I went anterior to that, and that's where I found, and I did my cochleostomy. So what I ended up doing to get the implant in was work through both directions. So I slipped the implant in through the epitympanum, or through the suprameatal approach, and then I worked through the canal with my left hand to grab it and insert it into the cochlea. So I ended up using a straight electrode on the left side, which was much, much easier, because getting the curved electrode around that bend on the right side was a challenge. So it worked out this way pretty well. The next slide had another option. If this doesn't work for you, this was a nice paper by Dr. Isaacson and Cameron Wick, and showed a sort of a closure, of the canal approach. I think this is probably a nice alternative to what I did.
That's fantastic. Other panelists, how would you tackle this with the lack of a mastoid?
I can
So
comment.
this is,
Go ahead.
okay, go ahead. Oh, I was going to say, I've had I tried the canal closure with a radical mastoid underneath it. It worked really well until about 2 years later, when the electrode extruded through the canal closure. Just because now that you have this large open cavity, it doesn't exactly coil. There are no real ledges. At least I didn't create any ledges at the time. And so that electrode was just obviously sitting up on the canal closure, and eventually, it just came right out.
Yeah, that's why with my little mastoid, that's why I did that, kind of made a little edge there. That helped with that, I think.
What I do with this, pretty much like what you did, Stephanie, but I do suprameatal. I take the incus out so I can get up high. I take a 1 millimeter diamond burr and drill it all the way out to the canal and connect it with my groove that I do in the mastoid. Then I take a 2 millimeter diamond just deep to that to make something that's kind of shaped like a triangle. The electrode goes in that, and then I slip a strip of cartilage, kind of like a tongue and groove if you build furniture. And you can see that cartilage that prevents it from extruding in the canal. The electrode, like you say, I tried doing a pre-curve before. The problem is your angle's terrible. So you have to kind of put it in, and then instead of pushing it in like this, you have to do it like this sideways. And it's awkward. So in that case, it looked like the CT scan showed a incomplete partition type 2. I'm not sure. But if I'm going to use a straight electrode, I like them at L, but I would probably use a 24, because if it's an IP2, 28 will be too long. But it's hard to put them in. You have to kind of, and then like you did, you blue line it. See, the problem is if you can't see the stapes, when I get lost in an ear, I use the relationship of the oval window to the stapes being within 2.5 millimeters. But if you don't have a stapes, you're kind of blind. So I like what you did. You kind of blue line stuff to kind of get a turn, figure out where the basilar turn is, and then kind of in it inferior. So cochleostomy is exactly what I did, but straight array is, I don't know if you can get a pre-curved one with it because the angle's terrible.
Right. Yeah, that's a tough one, but there's an elegant solution for sure. So we're getting up against it. I think I'm gonna jump forward, Tina. This is a great case, but it's like the Odyssey. We could take 2 hours doing this case. So we're going to jump to one last short case, and this is John's case. So John, a 7-year-old boy fell hearing screen at school, aided by instant alternatives, no history of infections or ear surgery, a speech delay, and the parents think it's a congenital hearing loss. And there's the audiogram and the tympanic membrane view. And then, John, walk us through this, your CT analysis here.
Okay, so I put this under the genre of congenital conductive loss with normal appearing tympanic membrane. Now, obviously, the most common thing you're going to run into is congenital fixation of the stapes, which is a noted placode issue. Second most common being a second branchial arch abnormality, which usually will involve displacement of the facial nerve, incus lenticular process, and the stapes superstructure. So I get a CT scan on every congenital normal appearing eardrum. This was curious because the radiologist called this normal, but I always like this view where you can see the three things: stapes, facial nerve, and horizontal canal. It should be stapes, facial, horizontal canal, but you see there's no facial. So this particular case, the facial is actually on the promontory. So normally when you have a displaced facial, you have to be concerned about what type of intervention you want to do. But this particular one was interesting. I say the typical second brachial arch has absent stapes and facial nerve displacement. That CT scan actually on another cut, you can see the stapes. So I thought this was curious because you have facial nerve displacement, but the lenticular process and the superstructure were normal. So it's kind of like a combination of a second branchial arch and a noted placode issue, which is really rare. But my first thought was, you know, he was on AIDS, he wanted other alternatives. And so I offered him surgery because sometimes when the facial nerve is so displaced, it gives you an option to do a conventional stapes surgery with a drill out. And I know there's options of, you know, when I go with the options, we talk Baha, we talk hearing aid. But, you know, if you really look at the options of Baha, it could be really expensive long term because in Arkansas, insurance doesn't cover it past 18. So you're going to have to get new processors, and the cost if you live to about 80 is about $100,000. So actually, I present it in a kind of a cost way. Anyhow, so if you go to the next slide, when you're thinking about doing, now if it's a tracheoplasty or something like that, if the facial nerve's abnormal, all bets are off. But I borrowed this from some book. The one that I usually see is B or E, and E can be fixed with malleovestibular but you have to be careful if you station 2 functions problem. But this particular one was D. So I thought this was enough room, and this was about 15, 20 years ago, that I wanted to explore this ear. And then the next slide basically shows this is the left ear. You can kind of see that the facial nerve is inferior to what, in this particular case did have a stapes, but it was fixed. And so we able to do a traditional stapedectomy, and he did great, stapedotomy, and he did great, and I did his other ear. And I've seen a couple of them like this since then. And it's interesting because I can't quite figure out the embryology of this particular case, but if the facial nerve's out of the way, the outcomes in the cochlea is normal. I think it's a reasonable thing to do.
So question, John, into the panelists, would you make this child wear a hearing aid or, you know, fail a hearing aid trial before you'd operate on them? Because I know that's kind of the controversy here is, you know, do you just go ahead or do you make them try it?
I make them try it. I make them try it because usually they're diagnosed, and I'm not going to do this until I'm absolutely certain there's no eustachian tube dysfunction. So I'm going to kick these down the road to 7 years of age, no earlier than that anyway. So they're going to need to be amplified. And if they're happy with their hearing aid and they're great, then you know, no foul. But oftentimes they're curious about getting rid of their hearing aid, especially when they go through adolescence and become curious about how they look.
Yeah. Sharon, what do you think?
So
It up in the Great White North.
So given that I have an exclusively pediatric practice, I'd call a friend on this one just because I think that you have to do a reasonable number of cases, you know, if you're going to put a fenestration in the stapes. And that's so I think that that's reasonable. I think I would have him wear hearing aids because, you know, he's got a bilateral auditory system and we're only going to operate on 1 ear at a time. But when it comes to mobilizing the stapes, we phone a friend that does it more often than we do.
Mm-hmm. Yeah, I think there's a threshold number of cases you need to be doing annually before you tackle these. That's really the value of our colleagues who are doing a lot of adults and doing the pediatric cases. So Tina, what about you?
So I am not a huge fan of operating on congenital hearing losses, no matter what the cause, really. And so for sure, they will always start with a hearing aid. And for a lot of the kids, depending on what age they start wearing it's kind of just part of who they are, and it's not a big deal. But I agree, once they get into their teenage years, that becomes a lot more of a difficult sell.
Mhm.
But I really sort of counsel the parents, I'd like to wait until the child can really at least kind of participate in informed discussion about what are the potential risks, and might they still need to wear a hearing aid if they still have some conductive loss.
Steph, what about you? How'd you handle it?
Similar to what John suggested, and everyone else too, that it definitely helps to wear a hearing aid first. And the way I counsel parents is a hearing aid is going to work 100% of the time. Surgery is not perfect. There's risk of sensorineural hearing loss. There's a risk of failure over time, but at least let the child try a hearing aid. And then, if they really want to explore it at a later time, understanding what the potential risks and complications might be, then I'm not adverse to doing it. I don't necessarily have an age where it's like, you have to be this old, but definitely lean towards waiting a little while.
So what is the level of conductive hearing loss that the group would agree to operate on, like in terms of a SRT? John, what's your cutoff?
I prefer, so the world works at about 50 dB. So that's where phones ring. That's where, that's where announcements are. So I like them to flip a 4 if I can, and that's usually going to be over 30 dB at 500. I'm not going to operate in it, especially if you look at it, stapes versus congenital fixation, it's different. The results aren't as good. So my threshold for otosclerosis is lower than it is for a kid. So I'm going to say minimum 30 dB conductive, preferably more. SRTs of 40 or greater.
Yeah, absolutely. Well, panelists, I think we're up against it, but I really appreciate your expertise. I learned a lot in this hour, and it was sure a lot of fun. I want to thank the ANS, and I really want to thank Brad for putting this together. It's been very enjoyable. So thank you to all the participants for your excellent questions, and looking forward to more great sessions today.
Thank you, Rob. You did a great job with it.
Thank you, Rob.
Thank you.